I want to thank SAGES for giving me the opportunity to present our review of esophageal and gastric perforations during laparoscopic foregut surgery. I and Dr. Michael Brunt have nothing to disclose. Esophageal and gastric perforation during lap foregut surgery has not been recently studied. In the mid-1990s, published studies suggest the incidence was 2%, and the most common mechanism of injury was during the retroesophageal dissection. Since that time, their experience with these operations have significantly advanced. However, there has been no studies that looked at this problem across the spectrum of foregut procedures. The purpose of this study is to identify intraoperative perforation during primary and revisional laparoscopic foregut surgery, specifically its incidence, location, mechanism of perforation, and complications and outcomes. This is a retrospective review of all lap foregut surgeries performed at Barnes-Jewish Hospital and Washington University Medical Center between the years of 2004 and 2012 by 5 attending surgeons. The cases were divided into lap anti-reflux surgery, lap paraesophageal hernia repair, lap reoperative hiatal hernia or paraesophageal hernia, and lap Heller, which includes both primary and redos. To identify the intraoperative perforations, we performed a chart review of all foregut operative reports. We also performed a thorough review of their postoperative hospital course and 30-day readmission. Data was collected on the number, location, and mechanism of perforation, as well as the postoperative outcome and complications. Statistics were done by Fisher Exact and Mann Whitney Hugh. We reviewed a total of 1,223 foregut cases. Of those, approximately a third were anti-reflux surgery, a third were paraesophageal hernia repair, and the rest were either redo hiatal hernias or Hellers. Shown here is the total number and percentage of perforations for each type of surgery. For anti-reflux surgery, the risk of perforation was 1%. For paraesophageal hernia, it was 2%. For redo hiatal hernia, it was significantly higher than the primary surgeries at 14%. For a primary lap Heller, it was 4%, and for redo Heller, it was the highest at 29%. This table shows the location of the perforations by procedure. For each procedure, there is fairly equivalent risk of having an esophageal versus gastric perforation, except for redo hiatal hernias where there were significantly more gastric perforations. Shown here is the mechanism of perforation. The most common mechanism of injury are highlighted for each procedure. For laparoscopic anti-reflux surgery, it was during suture placement. For lap paraesophageal hernias, it was during traction. For redo hiatal hernias, it was during dissection and wrap takedown. And for lap Hellers, it was during the myotomy. This table shows perforation by procedure type that was recognized either postoperatively or intraoperatively. In our study, it showed that 84% of all perforations were recognized intraoperatively and repaired. Interestingly, 100% of the redo hiatal hernia perforations were recognized intraoperatively. We then examined the difference between the intraoperatively and postoperatively recognized perforations and its outcome. When perforations were recognized intraoperatively, there was minimal need for reoperation, minimal need for any kind of postoperative intervention, with only one patient requiring a reoperation. Not surprisingly, perforations recognized postoperatively resulted in significant complication, with 75% reoperation rate and 50% risk of GI or IR intervention. There was also an 88% incidence of postoperative complication when perforations were not recognized until the postoperative period. In conclusion, in a high-volume center, intraoperative perforations are quite rare during first-time laparoscopic anti-reflux surgery and paraesophageal hernia repairs, and it is the highest during reoperative hiatal hernia repairs. Perforations not recognized and repaired intraoperatively required minimal postoperative interventions. However, when perforations are not recognized intraoperatively, even though these cases are rare, it does likely require abdominal reoperations, GI or IR interventions, and results in significantly more morbidity. Thank you.
Mike Holzman, Nashville. I was wondering if you could tell us, do you use intraoperative endoscopy routinely? Did that have a difference in ability to observe these intraoperatively? And the other is, what was the time in which the delayed perforations or the perforations were noted? What was the time frame until you noticed those postoperatively?
Okay, so for the first question, do we do intraoperative endoscopy? It is actually dependent on the surgeons. For majority of the Hellers, we did have an EGD intraoperatively to ensure that there was no leak. For the others, it was very variable depending on the surgeon. For the second question of when that was the postoperatively recognized perforations found, of the 8 that was recognized postoperatively, 4 were recognized within the first 1 to 2 days post-op, and that was either by upper GI or the patient had peritonitis. And the rest of them were found between post-op day 3 and 24. So.
Dr. DeMeester.
It was a very nice study. Was there any differences across the time frame of the study in terms of these perforations, which would suggest that maybe you altered your technique? For example, just looking at paraesophageal hernias, you had a high incidence of perforations related to traction. But we've learned over the years that you don't try to pull the stomach out of the sac. Mm-hmm. You just start the sac dissection so you get rid of that sort of spinnaker effect that you're fighting. So did you modify your technique, and did that account in some changes in the perforation rates over the time?
Right. I think that certainly this study, this is the first study that's been done for a long time looking specifically at this problem, and I think this study will actually help people then modify their techniques. But before the study, I don't think people were differing the way they were doing the dissections.
Dr. Soper.
Yeah, Nat Soper, Northwestern. So I want to follow up on his question. Did you look at it the first 5 years and then the last 5 years or something to see if there was a difference in incidence of perforations, number one? Mm-hmm. Number two, was this prospectively accrued data, intraoperative data sheets or something showing whether or not perforations occur, or was it all retrospective, going through 1,300 op notes to find if there's a perforation? And was it only full thickness perforations or also deep seromuscular tears that just required a stitch? Right.
The second question first. So this was completely retrospective, and it did require going through 1,200 charts. And we only accounted for full perforations through the mucosa perforations. And the first question was?
2 time periods.
Oh yes, 2 time periods. We did not specifically look at that, but I think it would be beneficial to actually look at that, especially given the volume that we have in our study, to see if there's a difference. So.
Great job.